One of the common categories of patients who come to us for a full mouth rehabilitation have periodontal pathology. There are certain teeth which are mobile and certain teeth which are lost bone but not so mobile. Certain teeth which are little painful and certain teeth which are not painful on percussion as well as you know independent of any percussion. Certain teeth which are sensitive and some of them which are not sensitive. It's always a challenge to the clinician how to treat these cases, whether to extract teeth, whether to keep some teeth, when do you treat the periodontal environment, do you need grafting solutions, do you need endodontic therapy, and of course, with all of these things, the concept of occlusion, building up new arch forms, and equilibrating occlusion as a final result. To add up to this, it's also sometimes replacement of missing teeth with implants. A clinician needs to go through all specialties of dentistry just to rehabilitate one case. In this presentation, we are going to be speaking about how do we approach such cases, and we will then discuss one case in detail where we consider all these aspects. Full mouth rehabilitation means we need to have a complete solution for the patient. It should be holistic, it should be aesthetic, it should have favorable occlusion, the patient should be able to speak well, it should have good healthy gums, and there should be balance in the entire neuromuscular and stomatognatic system. To achieve this, we need to know what is the starting point, but most importantly, we need to be able to imagine what's going to be the end point of our solution. Keeping the end in mind is going to be a very, very important way in which we are going to plan and navigate through these full mouth rehabilitation cases. Let's understand the significance of periodontal disease and their impact on full mouth rehabilitation. Many a times, periodontal health gets completely unnoticed, and dentists view more of pain related to tooth. So, along with endodontic, surgical, and prosthetic consideration, the due respect should be given to eliminate periodontal disease. It's important to have a well maintained, healthy attachment apparatus so that the bone support and bone health is maintained and the resistance to attack from the plaque and bacteria from the plaque is very, very good. This attachment apparatus is very, very crucial for the overall health of the teeth and success of your treatment. We need to treat the periodontal environment because we want to reduce the endotoxins from the pathogens which can destroy the bone, which can give rise to loss of bone and then with combination with other forces can lead to mobility. You need to understand that patient can have certain other factors which contribute to this. For example, he could be on hypertension medicines causing a little inflammation on the gingiva or the periodontal health is compromised, combined enlargement. It could also be that he's a mouth breather, as a result of which the gums are remaining very dry at night, as a result of which he is getting more inflammation. So it can be multifactorial, and you need to understand what are the factors in a particular case that you should look at. Those factors have to be eliminated as much as possible. For a mouth breather, you need to consider that the alignment of the teeth can be improved. Mouth breathing can be because of so many things. It could be because of infected tonsils, adenoids. It could be just because he has a deviated nasal septum. So many things needs to be eliminated. So, if you look at the definition of periodontitis, it's just an inflammation and infectious disease of the gingiva and supporting structures. It can be for the bone, it can be for the cementum, and the periodontal ligament, most importantly. The periodontal ligament is a savior for teeth, and groups of microorganisms which infiltrate this very crucial area and zone leads to attachment loss, subsequently tooth mobility and recession. This is also true around implant. We know that the attachment of the periodontium to the implant surface is far more compromised than that of natural tooth. That means peri-implant health has to be viewed critically, and certain factors like width of attached mucosa, maintenance therapy, leaving sufficient bone around the implant will be a very, very important aspect of long-term implant health. How do you recognize the problem when you have multiple teeth which have got periodontal problems? Patient can complain of foul odor, sometimes bleeding gums, pus discharge, recession of the gums, mobility of the teeth. You can probe into these areas, check the pocket depth, see whether the attachment has been lost. And all these things will allow you to make a chart or work on a chart and assess the overall health of the tooth and see whether this tooth can be saved on a long-term perspective. And long-term I mean is at least 8 to 10 years. Mind you, these teeth are mobile not only because they lost bone, but also because they are now in a compromised occlusion because of migration. So, let's look at this case and start understanding how do we go ahead with this case. This is our case for the day. Look for the pattern of the bone loss, whether it is horizontal or vertical bone loss, because vertical bone loss and angular bone loss can suggest of occlusal trauma as well. Furcation involvement, widening of the periodontal ligament, any abscesses that you see clinically, attachment loss on probing. Systemically, look at the levels of vitamin D3, B12, calcium levels, and glucose, serum glucose, blood sugar levels. Very important to know whether the patient has any other problems. History of medications. All of this should be properly registered to understand holistically what could be compromising on the periodontal status. Look at signs like for fremitus. If you think there is mobility in the tooth, try to feel the tooth and ask the patient to bite both on centric and eccentric and see whether there is functional mobility. It's very important because if there is functional mobility, it is the occlusal loading which is getting the periodontal ligament to shift dramatically and also leading to bone loss. So if that factor is eliminated, the tooth can become firm. So if your final restorations or your full mouth rehab is going to change the occlusal scheme, you might consider keeping such a tooth in the mouth. It's very, very important that you look at multiple factors around a problem that you see and see which ones or which can be solved by eliminating certain factors. Let's understand two terminologies, trauma from occlusion and pathologic migration. Occlusion in function, eccentric, swallowing reflex, the intercuspal position, all of this will keep the arches stable. However, sometimes Because of periodontal disease, the structure surrounding the root gets weakened, and these teeth can't bear the masticatory forces that they are supposed to bear in those excursions, as a result of which there is a little movement of these teeth. So the trauma from occlusion is defined as an alteration which develops in the periodontal ligament or the periodontium due to undue forces. And then what happens? As the forces keep on multiplying, the teeth keep moving away to reduce the trauma on their own. And this is migration. So pathologic migration happens when these forces start moving the teeth in the direction of the force. Unfortunately, as they move on, the vectors of forces keep getting altered, and certain other teeth get excessive loading and they start moving. So it's a cascading effect which happens. And you see multiple clinical situations with weird diastema formations. And this is predominantly because of imbalance in the occlusal forces. So the periodontal ligament obliges and the periodontium starts adapting to these forces. So when we are looking at the entire picture now, and that you have assessed it the way I said, you need to make a problem list. And the problem list in this case could be advanced bone loss, pathologic migration, trauma from occlusion, aesthetic and phonetic compromise. What are the problems? List it down. Understand which are the teeth which have lost substantial amount of supporting structures. It's very important to know which teeth to extract. Strategic teeth to be extracted, occlusion to be considered, aesthetics to be considered. All these aspects done according to planning that we usually do for full mouth rehabilitations. The problem list also will have supra-eruptions, abrasion defects, sensitivity, collapse in vertical dimension of occlusion, organizing maxillary plane for aesthetics as well as for function, curve, Spee curve, Wilson, how do you get it back? All of these factors needs to be considered to design the new maxillary occlusal plane and form, as well as the interocclusal height, that's vertical dimension of occlusion that you want to restore for the patient. When we are looking at the radiograph of this patient, you can see generalized advanced bone loss. You can see horizontal and as well as angular defects, multiple missing teeth, multiple teeth with poor prognosis, and endoperio involvements. Check the mobility of the teeth. Look at the probing depths around the teeth to understand what kind of bone loss patterns clinically and radiographically you see, correlate them together. And decide that some teeth can be saved, the others needs to be extracted. The ones that are saved, do they need root canal therapy? Is it a perioendo problem? And this is very, very crucial. Perioendo problems were not understood as well before as much as they are today. Thanks to the advances in root canal therapy, we have found multiple lateral canals lateral on the roots, which we were not aware of in the past. So when you start looking at endoperio problems, it could be a problem which is arising from the periodontium. It could be a problem arising because of faulty nerve or dead nerve. It could be a combined lesion. It could be something which has been also compromised by trauma. So pathologic migration, trauma from occlusion, trauma, death of the nerve. I mean, there are multiple reasons why you can have endoperio problems. When we see that the endo problem has arisen from periodontal pathosis, as a bone loss keeps happening, there are many lateral canals which can get exposed to these toxins, endotoxins. And these endotoxins will enter the pulp. They don't have to necessarily enter from the apex now. They can enter from the peripheral areas of the root, anywhere where you have lateral canals. And that infects the pulp. Surprisingly enough, moment you treat these cases with root canal therapy, the tooth becomes much more stable. The mobility reduces. Sometimes the mobility disappears. It's very interesting. And these teeth can survive for not only 10, but maybe many, many more years than what you think on the day you examine these teeth. It's very important as a clinician that these cases have studied well, because you can't beat a natural tooth. Whenever you have a natural tooth, it's going to be the best solution for you. A lot of clinicians have started believing that anything that you see is failing should be extracted. But believe me, if they have such a situation in their own mouth, they will not get it extracted. As clinicians, as doctors, we should be able to deliver the same therapy that we will do it for ourselves on our patients. We can't have two treatment plans, one for yourself and one for the patient. The moment you feel that your philosophy allows you to make a single treatment plan for anybody who comes to your practice, including yourself, I think you have got the right treatment plan. So saving teeth is very, very crucial, very important. And over the last 25 years that I see a long-term success with implant solutions that we have given to our patients, I see teeth are very important as well. Prosthetic solutions restored with multiple teeth as well as implants have lasted very well. It's important to save natural teeth as much as possible. Do your endodontic treatments properly for lesions which start from periodontitis. So what is the action plan for this case? Of course, first is to recognize all the teeth that can be salvaged. Make a comprehensive plan to save them. Good periodontal therapy and endodontic therapy as well. Deep curettage flap procedures wherever necessary. Extract all hopeless teeth and place implants. Make provisional restorations to stabilize. See that the provisional restorations are made according to what we advise. With diagnostic wax up, increasing vertical heights, making provisionals ready so that you can immediately provisionalize these cases. These cases have to be immediately provisionalized with stable occlusions. And then once the implants heal, after 17 weeks, you can then make your final restorations. Independent teeth and independent implant restorations. And now I think it's time for the first question and answer session.